to thank the organizers for inviting me for this talk, and thanks to Chairperson Sir for the very kind introduction. So I'm Dr. Gaurav Bhaduri, and my talk today is on the one-step versus two-step, the global screening controversies. So this is the clinical framework of what we are going to discuss today. And before we start into this, I will give you a little bit of a introduction about the historical origins of these two protocols and how they came into being. Then we'll recognize the clinical problem and why the GDM screening strategy actually matters. Then we'll try to understand the two approaches, what are the practical protocols that we can apply, and what are the key differences in between them. We'll then go straight into the evidence block and see what the trials actually show us. Finally, we go into the implementation challenge, and we try to understand that what is best for our own clinic. So if we go and look at this slide, what we understand is a 50-year controversy that has created a global divide. So back in the days of 1964, O'Sullivan and Mahan founded a criteria which is the foundational stone of the two-step strategy. But unfortunately, it was designed to predict the mother's future risk of type 2 diabetes rather than the immediate prenatal outcomes. In 1982, Carpenter and Couston, they modified this criteria, the thresholds, and it was adopted for a US practice. In 2008, the landmark HAPO study results came out. About 23,000 women were involved in that study. And it revealed a continuous link between the maternal glucose and the adverse perinatal outcomes. And based on this study results, in 2010, the IAD-PSG came up with its guideline. And the one-step approach was basically born from this HAPO data. And it was then very soon endorsed by the ADA and the WHO. The current global divergence still exists because ACOG still maintains the two-step procedure, whereas most of the international bodies across the world, they are in favor of the one-step. Now coming to the clinical problem, and as I was talking about, that why this GDM screening strategy matters at all. So if you look at this slide, we understand that untreated hyperglycemia carries a significant risk for the mother as well as the fetus. Macrosomia, shoulder dystocia, neonatal hypoglycemia, and as well as maternal preeclampsia and hypertensive complications all go up if GDM is undiagnosed or untreated. Now, screening strategy directly determines who is actually going to receive the treatment. If you look at the one-step, it has about 18% diagnosis rate versus the 8 to 10% in the two-step procedure. And there is, you can clearly see a doubling of the diagnosis rate, and we'll try to understand whether this increased rate of diagnosis actually means something. So understanding the two approaches is very important. So you see the one-step protocol is a very simple one. So you have a single universal diagnostic test, patient coming in the fasting condition, given a 75-gram oral glucose tolerance testing, and then you have three draws, the fasting, the 1 hour and the 2 hour, and if one abnormal value crosses the threshold, then you are able to clinch the diagnosis. See, the key challenges are that it requires an overnight fasting, and that leads to a significantly lower patient completion rate in the trials. Now, the two-step protocol is first a screen followed by a confirmatory test. So in step 1, we do a 50-gram oral glucose challenge that works as a screen, and it is a non-fasting testing. So you can test it at any point of the day. It's a 1-hour glucose test, and if the numbers are more than equal to 130 to 140, about 15 to 25% will actually go down the screen into the next step. Then patients can go ahead and do the next step procedure, which is a 100-gram oral glucose tolerance testing. Here, it needs to be done in a fasting condition, and then you have to draw 4 draws and use the Carpenter-Couston criteria to see that if there are more than equal to 2 abnormal values, and then you can arrive at your diagnosis. The good part is that over 90% of the patients actually complete the non-fasting screen, and only 1 in 4 to 6 women will actually require the full testing. Now you see over here the Carpenter-Couston criteria. You have the fasting 1 hour, 2 hour, and 3 hour thresholds. If two abnormal values, your diagnosis is done. And these two abnormal values actually confer the specificity of the two-step procedure, avoiding the false positives from any single elevation. Now, DIPSI, what is there in India, is a very nice Indian alternative. So it's a pragmatic, non-fasting alternative for the low resource setting. So you have a single 2-hour glucose measurement, and if it is more than equal to 140 after a 75-gram glucose load, and it's performed in a non-fasting condition, your diagnosis of GDM is made. And there are certain critical trade-offs. So as a strength, you have a very high feasibility because you're able to do it in a non-fasting state. The moment you see the patient, you're able to do it. And there is a very high specificity, about 98%, which is higher than the 1-step and the 2-step, for catching those cases with severe hyperglycemia. But the limitation is that there is very low sensitivity. The WINGS project actually showed us that about 22 to 28% sensitivity was there compared to the IAD-PSG. And in another study in North India and Sri Lanka showed about a 40% sensitivity. So it will miss 60 to 70% of all the cases that are actually identified with the 1-step. Now you might ask why this low sensitivity happens. Because in the fed state, insulin response is already active, what we call as a second meal effect. And the glucose tolerance seems to appear better, right? Yielding the false negatives. If you look at the protocols, they differ fundamentally in burden, stringency, and the yield. You need a fasting for the 1-step. For the 2-step procedure, it's only required for the step 2. For DIPSI, it's not required at all. The GDM prevalence about 18% highest with 1-step, and about 4 to 6% with DIPSI, lowest, and in between about 8 to 10% in the 2-step. The sensitivity is highest with the 1-step and lowest with the DIPSI. Again, DIPSI has got the highest specificity versus the lowest one with the 1-step procedure. Now, if you look at the evidence-based outcomes and what the trials are actually telling us, what we see over here is the Hiller et al. Study from NEJM in 2021. A large pragmatic RCT found no difference in the prenatal outcomes. 24,000 women randomized, and what we got is a GDM rate in the 1-step arm double than that of the 2-step arm. However, despite doubling the diagnosis rate, there were identical rates for large for gestational age infants, neonatal complications, and even cesarean delivery. This another meta-analysis from Brady et al. Published in 2022 showed us that there were no difference in the large for gestational age in the 1-step versus the 2-step. However, the neonatal hypoglycemia, the NICU admissions, and the insulin use was actually higher in the 1-step. But there are also certain evidences which can support the 1-step. These are two high-quality RCTs showing treatment of mild GDM improves the outcomes. So this is the ACOIS trial in 2005 and the MFMU trial in 2009. And remember, mild GDM is very likely to be missed by the 2-step and can be catched better by the 1-step procedure. And these two trials showed us that mild GDM, if they receive the proper care for GDM, will have a lower serious prenatal outcomes. Now, once we have understood all these things, the very important part is the implementation challenge and choosing the best strategy for your own practice. Now, high-risk population may benefit from a 1-step enhanced sensitivity. So there are different prevalence rate of GDM by ethnicity. And in a population where there is elevated prevalence of diabetes risk, like the South Asian, Hispanic, and the African American compared to the Caucasian, 1-step may be a better choice. There are strategic considerations. So in settings where your access to emergency C-sections is extremely limited, preventing a single case of macrosomia becomes even more critical. And the 1-step higher sensitivity might be advantageous in this particular situation. Then you also need to understand that resource constraints favor more efficient screening strategies. So first and foremost, you need to assess the capacity. So evaluate the lab throughput, the staffing, and your burden that you're putting on the patient. If you have got a moderate resource, 2-step is a strong choice. It reduces the OGTT burden as only 15 to 25% of the women will actually require the full testing. If you have got severely limited resources, DIPSI can be a very good alternative. It allows for universal screening where a fasting OGTT is not feasible despite a little bit of trade-off in the sensitivity. And remember, the best test is the one which a patient actually completes. Actually completes is the most important part. So if you look at the real-world completion rate from the trial data, the two-step glucose challenge screen was completed by 92%, DIPSI about 80%, and 66% for the one-step fasting. Now, this question that what about the long-term outcomes is probably the great unanswered question in this particular domain. Because we have talked about the short-term immediate perinatal outcomes in pregnancy, and the current evidence does show equivalence. But in the long term, what about the maternal and offspring health? So one step identifies more women with prediabetes who are at a higher risk for future type 2 diabetes. And this allows for earlier intervention, both lifestyle as well as metformin intervention in this group. For the offspring, ongoing studies are trying to assess if milder GDM reduces the child's future, if treating the milder GDM reduces the child's future risk of the metabolic syndrome. So the hypothesis here is that the benefit of the one step may not be in the current pregnancy, but in preventing the future disease. So the take-home message is that no clear winner for the perinatal outcomes. Head-to-head RCTs show equivalent short-term outcomes. The one-step strengths are its higher sensitivity, a global standardization being adopted by the major international organizations except the ACOG, and a potential for long-term benefits. We don't know that as of yet. The two-step strengths are it being a resource efficient and superior patient adherence, especially in the first screen that you do in your patients, and a proven effectiveness in the landmark US trials, and has been there in the US for multiple decades in use. The choice is a context dependent. Weigh your own population's risk against your system's resources and capacity. DIPSI is a very pragmatic compromise here in India. It enables screening in low resource settings, but clinicians must be aware of the low sensitivity it might provide. So a final consideration for your practice. So when selecting GDM screening strategy, consider the local population risk, available resource, and your capacity for a long-term follow-up of those patients. Both the approaches, when properly implemented, are extremely effective at identifying women with a treatable hyperglycemia. So you need to put a little bit of your thought into what practice you will adopt in your clinic, because the thoughtful choice is always the right one. I thank you very much for your patient listening.